Schuster, HSCRC.
Shuri Gerovich, HSCRC.
Donna Kinzer, HSCRC.
I'm Dr. Zahid Butt, CEO of Medisolve, but here in my individual capacity, not representing the company.
Tracy Laval from the Maryland Hospital Association.
Trisha Ratty from the Medicaid program.
Laura Goodman, Medicaid.
Richard Day, Johns Hopkins.
Tony Tucker, OPM.
Chad Perman, DHMH, Population Health.
Hi, Stephanie. I hear you just joined. She's with Healthcare for All. Great. Well, and then we have several folks also with us in the audience. So thank you for coming, and we'll go ahead and commence with the meeting. First subject on the agenda was just to provide an update on the flurry of transformation activities the Commission and the industry and all stakeholders are undertaking together. So with that, I'll ask Donna to, if she wouldn't mind, just giving us the update on that.
Thank you, and good morning. We've officially finished our second year of the all-payer model, and pretty soon we'll have performance measures for the second year, although we do have some lags in time that we get our information in from Medicare. But for those of you following the model, in the first year we met all of our performance requirements for the model, the quality requirements. We exceeded our savings requirements for Medicare, and we exceeded our revenue. We actually were under our revenue growth caps for the all-payer portion of our model in the state. In the second year of and all hospitals went on global budgets, which was something that wasn't initially required until the fifth year of the demonstration. So we were ahead of schedule in how we were moving forward with our payment transformation. In the second year of the model, we really focused on potentially avoidable utilization and measures of utilization so that we can track what's happening with utilization in the state. And what we have seen on an all-payer basis in the state is that utilization is flat. So that's good compared to our historic situation where we had a fairly sizable growth in utilization year after year in Maryland. And I think it's especially good since we've come off expansion of Medicaid that we can actually see that our numbers have remained pretty flat in Maryland during the process. In terms of what we're hearing in the rest of the country, flat utilization in the hospital is good, and we're actually hearing about growth in the rest of the country on an overall basis. That being said, even though we're actually reducing our utilization for Medicare, we need to accelerate that process to make our all-payer model work on an ongoing basis, and also the planning efforts that we've been undertaking this year are for care delivery transformation that goes beyond the walls of the hospital, with a particular focus on high needs and complex patients, as well as individuals with multiple chronic conditions. In July, and actually from the onset of the new program, all hospitals in the state have been given funding for efforts to reduce potentially avoidable utilization. And we had investment reports coming in for fiscal year 2014 and 2015 this past October. And also hospitals were required to file a system transformation plan as part of the update process that took place on July 1. And those transformation plans were to address the short-term and long-term strategies and investment plans of the hospitals for improving care coordination and addressing the high needs and complex patients, as well as addressing patients with chronic needs. And we're estimating that there are about 40,000 high needs patients in the state that need intensive interventions, and another 200,000 plus Medicare patients, and we've particularly focused on Medicare patients with chronic conditions that need intensive care coordination in the office setting, and they may need some other care coordination supports as well. And we focused on the Medicare patients because under the fee-for-service system, those patients historically have not had the same supports that are available to the commercial population or the Medicaid MCO population in terms of some of the care coordination supports for those individuals. So the plans were filed by the hospitals on December 7th, and we've gone through a process of summarizing both the historical investments and the systems transformation plans. We're in the process of continuing to evaluate what we learned from those plans. I think what we're very intent on understanding is how will we execute on the strategies to scale up to really improve the resources that are available to the 40,000 high needs and complex patients, as well as the 200,000 or so chronically ill individuals who need additional supports in the system. And in particular, how will we do this in alignment with non-hospital providers, with physicians, long-term care facilities, and other long-term and post-acute care facilities and other non-hospital providers. So those are some things that we're currently focused on in terms of evaluating. We also received reports from the regional partnerships for health system transformation, and these were grants that we started out with earlier in the year to encourage regional approaches, because we're very intent on getting patient-centered approaches out of the transformation process. Many patients travel, the majority of patients in urban areas who have high needs may use more than one hospital. And of course, the number of hospitals that they use is exceeded many times over by the number of doctors that they use. So we really need to be focused on how to move information around the system to help improve care for our patients on a patient-centered basis. So that was the basis for really driving forward in the regional partnership focus for the health system transformation. I think we've we also have accumulated those plans, and at the last commission meeting, we reviewed all of these, our preliminary assessment of all of these plans with the commission. And I think the things that we're really trying to assess now is how specific or how complete are the plans to work together with the community providers and community organizations to execute these plans, and how can we accelerate the process to move forward with the implementation of these plans and processes. Last but not least, on December 21, we received 22 implementation plans and proposals, and we're in the process of reviewing those plans at this time and trying to understand exactly where hospitals and health systems and the delivery system is in being ready to execute on the strategies to accelerate the process to address the complex patients and the chronic patients. And I think this is a very significant and high priority strategy of the field. It was something that came out of the care coordination work group, which was a multi-stakeholder and multi-state agency work group with hospitals, community providers, and multiple parts of the state represented in that process to develop the overall plan. So I think one of the things that we'll be particularly interested in as we move forward with performance measurement is making sure that we develop performance measures to see how we're doing in terms of implementing these plans inside and outside of hospitals, and how are we doing in terms of accelerating the process to get more support to the 40,000 complex and high needs patients and the 200,000 chronic individuals with significant chronic conditions that will become complex and high needs patients if we don't help address their needs at the right place and the right time and the right cost. So I think that's a quick update on where we are and really what we're wanting to make sure that as we move forward with performance measures that we're taking this into account in the development of priorities and changes in performance measures. I am going to step back out, but I would be happy to answer any questions that anybody might have before I step back out.
Yeah.
Any question from the phone? All right. So
thank you.
With that, what we did initially is for the implementation grants and the regional partnerships, you may recall a long time ago we were working on scorecards and list of measures. So from those work, we pulled the ones that you suggested to us in terms of the key measures, and we are creating, CRISP is going to be creating some dashboards for each regional partnership and the implementation grants to monitor these trends. So in the first one is, and we called them earlier core measures, and that got created confusion, so we changed to key, HSCRC key outcome measures, so measures are the same, title changed. We are trying to, in this key outcome measures, obviously we're looking at the total cost, but also some utilization metrics. The first one is the hospital cost per capita, second is the admissions per capita, and the third one is the total cost. So we are hoping to get the Medicare data to help us initially, and as we get the other provider claims, we do have access to Medicaid claims right now, so we are going to be working on creating a total cost measure for the population that will be addressed. And the next one is the ED visits, readmissions, potential avoidable utilization, and patient experience and the composite quality. As you know, there are a lot of measures on the patient experience that we use in the QBR, so we are hoping to get one easy, simple indicator to show that what the situation is there. And the idea also was to create some composite measure, and hopefully our strategic discussions and the work for the next year could help us to think about what that could look like. In terms of the populations, you know, we are going to be looking at this on an overall basis, but also we would like to look at the target populations. And as Donna mentioned, it could be the 20,000, the high-risk patients, one cut. The other one is the 200 with the chronic conditions. And also if the implementation grants or the regional partnerships are addressing particular target populations, then that will be another matrix to look underneath these measures. At the commission meeting on Wednesday, when the work was presented, commissioners were very interested in looking at some of the process measures. Even though, you know, the field is moving on outcomes, since this is such a new endeavor, you know, it may take a while to get the outcomes show up as the impact of these. So are there things that we could monitor in the meantime, but also get a better sense of our implementation progress? And these are, so the process measures were designed to kind of get that information at a glance, and looking at the encounter notification alerts, and this is going to come from CRISP, the completion of health risk assessments, established longitudinal care plan, shared care profile, and also the portion of target population that has a contract with the care manager. So these are the ones that will be very specific to the interventions. But CRISP, since they could leverage the infrastructure that they are developing under the care coordination work that they are doing, we think that we can leverage them to come up with these measures and then help us in the measurement and the monitoring. And lastly, the other area was the cost of these interventions. So this is kind of similar to our GBR infrastructure report. So we required hospitals to submit the investments that they were doing under GBRs. But this would be kind of trying to calculate the return on investment for these specific interventions. And I'm not going to go through it, but we provided this to regional partnerships and the RFPs to think about how they would calculate the return on investment and the cost of their interventions. So I think this is going to be work in progress, so we wanted to give you an update and kind of get your initial input on those measures. And as we are thinking about the next phase of our performance measurement, I do think that this is going to be care coordination is going to be a big area that we would be focusing for measurement and also payment adjustments. Any questions on the measures? Yes, Dr. Bhatt.
So just a couple of questions. So some of these cost measures and the outcome measures, will they be risk adjusted?
I hope so. I want to get the trend first, but so that's a very good question. So there is another work stream at CRISP that they are looking at patient-level risk adjusters to evaluate their predicted values. So they looked at ACGs, HCCs, and 3M product and a couple other commercials. So they are trying to figure out what will be the best measure to use. And if we can find some analytical tool, it may help us in several areas: identification of high-risk patients, risk adjustment, and also in our work at HSCRC to think about how we would develop a the efficiency measure that you know, per capita measure that could also be used for that. But I don't expect that to happen quickly. I think right now the dashboards are going to be not risk adjusted, and we'll focus on following the trends. And as we work on the risk adjustment, I think the idea is to start risk adjusting all those measures.
Would there be an opportunity to comment on draft specifications of these measures when they're developed?
Sure. Yes. I think this group could be a good place to bring those back to you and then get your input on.
Great. Thank you.
So this is Tracy. My question is really just about, I want to make sure I understand we're using the measures that we have in front of us for the regional partnership reporting. And then, is that right?
For the implementation.
And implementation grants too.
The implementation grant.
So we have kind of three, if we go back to, so the strategic plans Donna talked about, that's a high level that we got early December. And then regional partnerships started last year, and they also submitted their reports, and we communicated these measures with them, and they were supposed to put them in their reports. And the third is what we call the transformation implementation proposals. That's the competitive grants that was set aside with the update factor, that we were looking for plans that are ready to implement, to jumpstart us. So those were the I think two, regional partnerships and the transformation plans. On the GBR reports, we didn't focus on the outcomes as much because GBR infrastructure reports were kind of looking at the expenditure side, how much money hospitals are spending on investment. But the feedback we received from the commissioners was that they wanted to see more of outcome and process measures in those reports too. And I think we are planning to bring together a subgroup to think about it and try to get that input into the GBR infrastructure reports. And then we could report back to you again after that subgroup works.
Got it. And the strategic plans, I haven't looked at those. So are these outcome measures and process measures, are they supposed to be in the, no, this is just strategies to address things, and you would expect these metrics to improve.
Right.
With that.
I think in general, potential avoidable utilization reductions is the strategy, and we were looking how hospitals were envisioning it to do it in the strategic plan at a high level, but we weren't looking for, outcome measures there. But in the direct implementation, if you're ready to implement, how you're going to measure what you're doing, what outcomes you want to have, and this list is supposed to be the minimum list that we would want everybody to kind of measured and looked at, but obviously we expect that the applications may have more measures depending on what they were trying to do. And I don't know if, Allison, you want to comment on what they've been showing. I haven't
In terms of the infrastructure or the planning grant?
Planning grants. And,
I think, all of them sort of reference that they're going to follow these key, I'm still learning the key outcome measures, and then some of the process measures that follow, but then they also offered additional process measures that were more specific to the interventions that they proposed.
Quick question. On the ROI calculation, the percent savings are basically based on some assumptions that are based on some prior data, or they're just going forward assumptions?
Actually, I'll comment on it. I think the idea was that, yes, you would justify what you thought your gross savings amount should be based on what you were proposing. I think that the references to how they were getting those numbers were sparse in the planning grants, in our opinion, at this point. And so we need to work on kind of getting them to better provide us how are you judging this estimate.
And one last thing, you also mentioned efficiency measures, and is the idea that these metrics are in the reporting right now, and then will efficiency may pull from some of these?
No, that was the
Look forward.
no. So that was the risk adjustment.
Okay, I'm
Those who are on the phone, would you mind muting yourself? We've been hearing the background noise, and I'm going to get to you if you have any questions in a minute.
There's a meeting going on the phone here, but I'll call you back or put a note on.
Somebody is on the phone talking to on his cell phone. And don't put us on hold. Think so. I think it's our IT person, actually. So he's not listening to us, obviously. The efficiency is about, like, if we get the HCC or ACG type of risk adjustment methodology, you know, that could be used in multiple places. So that's what I was saying, not these measures. Okay. So if we come up with a efficiency measure, hospital per capita, on the per capita, how do you adjust that per capita number? And there we would need to have some kind of a patient-based risk adjuster as opposed to our DRG.
Okay. And then that's when you went on to say, sorry, that the dashboards, for now, for starting, they would not be risk adjusted.
Yep.
Okay.
And because we're going to be looking at the trends, you know, we are not measuring what the total is, so we are less concerned at this point, but eventually we need to risk adjust.
Right. I think the key from an accountability standpoint would be whether those patients are kind of mutually exclusive to these regions and whether there's an overlap between the care that they receive. So.
Yes, good point. In terms of we said that the population for covered zips, we are looking at whether it's going to be the GBR zip codes or some kind of another primary service area zip code. So for the regional partnerships, the idea is they are focusing on a geography jointly. And it will be easier to think about that and then keep the accountability at that level. You know, the denominator for the implementation grants is a little murky. It depends on what they are proposing to do. And from there, we need to come up with a denominator to track, yes.
Within the grants, are they identifying the population that they're addressing, or is that going to have to be defined after the fact?
No, they are identifying the target population with the zip codes of where they're looking at. And
any question from our virtual guests? There is one that I got from Diane Kipley about, can you estimate timeline for notice of regional partnership awardees? Just to clarify, the regional partnership grants finished. We got the 2 reports from them. One was their work in progress report back in the fall, and then the final report that came in December. Now we are in a different cycle. The transformation grant is open to everybody, not only the regional partnerships. Regional partnerships applied for those grants, but there won't be any regional partnership grant anymore. So we are now in the transformation grants. And in terms of the timelines of the transformation grants, I would give
yeah, I mean, originally the timeline had been we wanted to go to the commission in February with recommendations. At this point, we've had 1 meeting to review them. I was in here for 7 hours yesterday, I think. And we're going to have another follow-up, plus potentially some additional conversations with individual applicants. And so I do not anticipate we'll have it in February. I would hope we would have it in March, but Steve Ports would have to weigh in on the definitive timeline.
Any other questions? All right. Then the next topic is the consumer dashboard. We've been meeting with the consumers, and Diane is leading our work on that consumer engagement front. And one idea that came out of those meetings was to come up with a consumer dashboard that we could publish on our website, or create press release to look at from the consumer perspective and assess the impact of the all-payer model for the things that matter to them the most. So now I think, again, we brought the list to you for your feedback and also kind of get you all knowledgeable about all these other performance measurements that we are doing that is not related to the payment aspects of it.
Right. So thank you. So mainly we received some early and really good feedback from Lenny Preston about the measures that she had been thinking about, had been gathering from her consumer constituents. So she was representing others as well. And I would say the main concern was what might be some unintended consequence of global budgets. So that was probably a very educated view of a consumer was reflected in that sentiment, because I think that it may run the spectrum where some consumers may not be aware of such implications or potential for implications of a global budget on how practice might change at the hospital when someone goes to the hospital. So the first one then, in context of that, is what's happening with the number of observation stays. And you see the data source is all HSCRC data except for the ED measures, which we'll talk about in a few minutes. So there are hospitals using observation more because they're not admitting, and they should be admitting. That was one question that that was brought up. The number of transfers as well, were patients being dumped or shed because a hospital didn't want the risk of high-risk patients. So that was a concern and something that they wanted to have measured. So the other issue was, are the incentives driving the decrease in the number of beds and or downsizing in the hospitals? And then would there be, from a consumer standpoint, sufficient capacity for the needed care in the respective communities? And then for that one, MHCC CON would be the data source. And then the hospice palliative care use. So here, this kind of had two ends to it. One is it should be used, and patients should be offered the appropriate care. Palliative care should be used when it's appropriate. Hospice care at the very end of life should be used. And so that was kind of one view. The second view was, are patients, are these services being provided too quickly and too often, and when it wasn't in line with what maybe patients or families would desire? So there were those sort of opposing perspectives presented in light of this hospice and palliative care measure. Staffing levels, there was concern that there'd be cuts, particularly in the ED or particularly nursing staff. So those were, and maybe physician staff. So the people who take direct care of patients. The measures that so far have been brought up. So I will ask Shulay if she wants to add anything, and then we can have a discussion about any input.
So I do think, the perspective consumers brought to us is about the unintended consequences. But at the same time, in some of these measures, whether it's increasing or decreasing is a good thing or not. Like especially we discussed the hospice palliative care measure, saying that I do think it's important to look at the trends and have a longer time period, not just the start point in January 2014. We need to have what was happening before to really see if it's really the impact of the old peer model, but also take this and think about the context and what is happening rather than making a judgment of whether it's a good or bad thing just because increasing. I think the challenge will be in that regard. Certainly, the times, there is no question there, but the observation stays, transfers, beds, even staff, those are, to me, are kind of the measures that we want to monitor, but then we would need to do a lot of work interpreting what those trends would mean.
Shule, was the idea that some of the key outcome measures might be presented in some way alongside this,
yes,
or just?
I think so. I think that was actually the purpose of presenting those transformation and partnership key metrics, were that we could build upon those, and why reinvent the wheel, but as sort of displaying or presenting or communicating to the consumer audience is a different task altogether than talking amongst ourselves here and to the provider and payer audience. So there again would have to be lots of work done around how you message and what does it mean, why is it important.
Diane, can you hear me? It's
yes.
Therese. Yeah. This is great. As you know, we already report the ED measures, the inpatient, and we'll be reporting actually tomorrow the outpatient ED wait times. And this is a great opportunity for us to collaborate where we can use the Maryland Healthcare Quality Reports website as a vehicle to provide some of this information, as well as what you may provide on the HACRC website. Because we're in the process of doing some focusing on promoting the website more widely to consumers so we can collaborate at the same
right.
time.
So Teresa, your offer is on the record and recorded.
That's all right. We do, even on the website now, we have these feature topics, and one of the topics has to do with healthcare costs, and we talk a little bit about the Maryland rate setting system and how it's unique. But it really was a placeholder for what we envisioned as a broader topic where you can share additional information that you want to get out to the consumers, and then we can just build on what we have. So this is perfect and really good timing too.
I think from looking at the things listed, ED wait times and those kinds of things, I think make perfect sense. And the fact that we already have some of that data available, it makes it much better and easier to use. I'm a little concerned when we say hospice and then we attach palliative care. Palliative care oftentimes has nothing to do with end-of-life care. It's dealing with a chronic issue. So palliative care many times is not used when it should be, but it's on how the patient or family can deal with whatever they are. So tying those things together is a little scary to me because they can be very different purposes of how
right, and so that's a really good point. So we probably should split them, I think. And yeah, thanks, Dan.
Yeah, I think, and Diane, you may have mentioned it, how difficult it is to really modify the message for a consumer audience. But this really will create an opportunity to get data out there and information out there, but also to educate consumers on what those differences are between, for example, hospice and palliative care. Because there's quite a bit of misunderstanding, as you all know, out there now. When someone hears the word hospice, they view one specific, they have one view of what that means versus some of the other terminology that they may be exposed to. And then, of course, we'd have to rework the wording of some of this so it's more understandable to the lay person or persons who are not in this field. So.
Yeah, this is Velma. I was thinking the same thing around observation stays. We see all the time that consumers don't understand the difference from when they're in an observation stay and when they've been admitted.
And that's where this document can help to educate consumers. It will be a lot of work to do it right versus putting out just a dashboard, but that narrative and that educational material that supports the dashboard will be key as well.
Dr. Butt?
Thank you. So the measures that are looking at the observation days, transfers, and staffing levels, is the intent to look at the absolute number or some sort of rate? Because it would be, I think, sometimes dependent upon the total number of admissions and so forth, which will determine. So an absolute rate may or may not give the accurate picture for these types of measures. Even on the staffing level, that's usually based on some ratio to certain types of care that you're delivering. I understand that these are for the consumer, so you can't get too sort of granular in these things, but I would think at least a discussion on what an absolute rate, absolute number versus a rate would mean. And the other thing is, I think that obviously the scope here is more utilization focused because of obvious concerns within GBR. But my sense is that the number of consumers that are honed in on these type of utilization metrics is a relatively smaller number. The majority of consumers really care more about the clinical outcomes, and especially composite clinical outcomes for the care that, for the conditions that they have. So I think it'd be a good idea to combine this with, I think the other website does have some of those types of outcomes on some more clinical measures, but more designed like CMS moving towards a star rating system and so forth. There's a recent report that there's an organization that actually ranks states based on how well they do on public reporting, and Maryland obviously got the NF on that, which was not very good. So I think it will be good to perhaps review that report as well and see how we may be able to enhance the public reporting side of quality and patient safety, as well as utilization in Maryland.
This is Tracy. I like all of these comments. I think they're very helpful. I think it is good to address consumer concerns and particularly to combine this utilization with the outcome measures where we have those and are reporting that, because I think it is an important point that it's the messaging around all of these, that you could look at each one of these metrics and say, is an increase good or is an increase bad? Is a decrease good or is a decrease bad? It depends on what else is going on. And when Diane, when you went through these and talked about why each one was important, you were saying all of there's questions behind each one. So I think that's important. So I imagine we're going to come back to this again.
Yes.
One specific question that I had was on the staffing levels. When we say the data source is the annual filing in the Schedule D, just a question about whether that information is proprietary or it's public.
No, it's public
information.
Yeah.
Okay, I think I'm confusing with a different wage and salary report that is proprietary.
Right. So this is the full-time equivalent reports, and I don't think we wanted to have the nursing staffing, but from the report we won't be able to differentiate it. Right. So we need to work through a little bit to come up with a measure. But at the same time, it will be important to come up with some kind of a measure that will control for the utilization, obviously.
So Magnet hospitals have a nursing staffing measure, and it's a standardized measure. But I think there's 5 or 6 Magnet hospitals in the state. So and they have to report that measure. So the benefit of that would be to to use those specifications and replicate the measure, but that would mean additional reporting for hospitals that are not doing the magnet program. So you know, we're exploring data sources around staffing as well. But it seems like using what we already have readily available and looking at trends overall, and sort of bumped up against probably the volume of patients that hospitals are seeing would tell sort of an interesting story over time, as opposed to sort of tracking how many nurses were in the hospital this month. Or, you know.
And I think that's probably the biggest concern, and gets back to using a ratio rather than an absolute number, because but in either case, measuring the staffing that's in a particular unit isn't really telling the quality of care or the speed of the care, which is why ED wait time makes a lot of sense, because people want in and out, and that's what the expectation is. And quality of care can be measured in a variety of ways, but staffing is how you get to those two results, the quality of care and the speed of the care. So those should be the measures, and the organizations need to figure out what's the right staffing to hit those measures. So I just want to make sure we're not getting to too much detail that leads to a whole lot of questions and a whole lot of other angst on, you know, the part of different parties that may not really, in the end, provide any better either wait time or quality of care.
Right. So you're right. There's not science sort of to link the two necessarily, but you can make a little bit of a leap, I think, from a consumer standpoint. If you see less, if your perception is there's less people to take care of you, so we have to figure out what that means and how to fit it in, if it fits in. You know, AMI care with the process measures sort of does the same thing around a clinical condition, and then presuming that at the end of the day the patient did better with those process measures. But you know, there is some science linking those two as well. So Stephanie, did you want to talk, Stephanie? Can she unmute? Oh, okay. Okay. So Stephanie is from Healthcare for All, and she agrees that providing context to this information, easily understandable to consumers, would be beneficial. She likes to rest a suggestion to include this information on the consumer website. She would also be interested in knowing how the measurements of the PPCs discussed at the last meeting would be shared with consumers. So we do report that data. That's a good point, on our website, and we mostly reported it.
Oh, yeah, I mean, it's not user friendly. It's not meant for consumer consumption.
Not at all.
You know, I think that's the conversation we need to have with the Maryland Healthcare Commission, how we could incorporate it and come up with a measure. We're going to get to it with the scores we use versus what the rates are. Not really one-on-one relationship, and I don't want to give a wrong impression to the consumer seeing high score in ours, meaning that they improved but still have high rate. I don't think that will be reasonable.
So I had a phone call about 3 weeks ago from a man who said he was coming to care in the state, and his area code was not here. So I knew he was from out of state, and I think he was coming to an academic institution to get a very serious surgery. So it was a choice, but he really needed to have it. And his wife is a physician, and I think so he told me a story, and then he asked me, can you please share infection rates with me? So I'm thinking, you know, I can give him the PPC tables. So I went into a very long, drawn-out explanation about how the PPC rates are very difficult to understand, because the methodology really, you have to understand that the patients, the comparisons are like patients, but then there's the nuance of, we've heard some concerns about, do they really compare like patients in small hospitals? This is not a small hospital issue. How do you explain that to a consumer who's in Massachusetts or wherever he is? And then, so I did share with him the CMS measures on the NHSN, which say, I think they do better, worse, or the same as the nation, and he was not happy with the level of granularity with that answer. So he's asking me for rates, and actually I still have to get back to him because we've been going back and forth. I want to make sure that he's satisfied with the information. And I had one other woman ask me about infection rates in another academic institution. So there are two, the largest academic institutions, and she wanted to know about hysterectomies and infections. So, there are people who are quite interested.
Oh, definitely. I think, and this is a perfect example where he is only interested in knowing whether an institution will provide safe care, right? So that's his primary concern, but obviously he's married to a doctor, so he needs to look into the details.
He wanted rates. He asked me for rates. So I'm trying to figure out how to give him rates. So.
And maybe I can really appreciate this. I would want to know the same thing for my family member too. I think if I were to approach this, I might ask my doctor, or I might ask the hospitals I was considering, and I would expect that either one would give me those results, particularly when we know they're published. But
yes, and that was part of the conversation. But I think there was a notion that there may be an unbiased view on what those answers are. So and sort of a third party kind of, and a government, so that we hold a different level of influence, I suppose, or whatever that right word is. Yeah. Neutrality. Thank you.
Diane?
Yes.
This is Teresa. In terms of infection information, on our website, we spent quite a bit of time with using focus groups, consumer focus groups. We do have that information utilizing the NHSN data, and it provides very simple information, including just a performance metrics or a performance symbol, but you can drill down and get actual raw data, or you can get rates. So it may be worthwhile if this group is going to move into how we present to consumers, to kind of show you that again, because I think it's a good starting point, and we continue to outreach to consumers to get additional ways to present information to this healthcare information, health infections information to consumers. But we have a really good start, and we've worked with CDC to come up with guidance on how other states should present this information. So some of that work is going on, and some of that information is provided on the website that might help your caller.
Okay, thank you.
I think I just want to make it clear, Teresa, I don't want to, that's your expertise, and CC is in charge of public reporting. I rather collaborate with you and then bring the information back to this group rather than working with this group to come up with a consumer information strategy. I don't think our expertise here is aware of the payment. Yep.
Right.
Yeah. The other point I wanted to make too, with the dashboard and the different measures that you have, as we all know, this is really complicated stuff, and even more so in trying to communicate it to consumers. So what we found is if we could just focus on one thing at a time, perhaps the ED wait times at this point, and then just work through how that's best communicated to consumers and what is it that you want to communicate to the consumers. And then we share that with you and then move on to other metrics before we take all of these.
Right.
You may just want to do it incrementally.
Right. Very good point. Thank you, Teresa. Very quickly, Ben Turner, do you have anything to say? Because he's our other consumer, and he want to give him an opportunity. Okay. All right. So next topic is the MHAC 2018 policy, and that policy was reviewed and approved at the commission meeting last week. So we wanted to go over it briefly. And then along with that, sort of where the final PPC list stands, and that's based on the inputs that we received from this group. So first, the specific recommendations include continuing the same scaling approach, and that makes a contingent scale, so the amount at risk is higher if the statewide goal of improvement is not met and there are no rewards distributed. And then there also is a hold harmless zone in the scaling, so that that will be created so that payment adjustments will focus. So in the middle, hospitals will be, quote, held harmless, and the adjustments will focus on the ends of the spectrum, very good or very sub-performance. And then the statewide target then was set at 6% for improvement. And the base is fiscal 15 with the performance calendar 16. So we are, of course, 2 months into the performance year. 20 days. 20 days. Okay. In terms of the list, we see this is not new, so we'll go over this pretty quickly. But I wanted to thank the group for providing the input on the Tier 1 and then other tiers, what we should put on hold, and what should be clinically combined for the fiscal 18 policy. So we see the Tier 1 measures. Then we'll put some measures, we'll still monitor them and put them in a monitoring status, and that's 5 PPCs that we see on this slide. The next is those that should be combined, will be combined for the policy. And these are clinically like measures, except for the last 5 on that slide, which are ones that we did that were very, very low in volume, that we have combined in the previous year. So we will keep those combined in PPC 67. And again, I want to remind the group we did analysis on the results, modeling different ways to combine these measures or dropping some of these, and there really wasn't any measurable, or there was non-significant difference between hospital performance when it came to the scaling. So we just wanted to present that list. Any discussion about it?
Just for my clarity, we are going to move forward with this list and redoing our reports. We will include in our reports anything that we've, in this last round of reports, we didn't provide the detail underlying like the combined PPCs. So we'll be providing that so you can go in and see, you know, what is making up that combined, as well as obviously monitoring the ones that aren't included in the payment program. So we'll be making that modification to the reports.
Question, what is the proposed weighting for the 2 tiers?
100% and 50%.
All right, so there is a technical update that we wanted to share with you. We had a discussion, and I appreciate BRG's help on this in terms of thinking this through. The small versus large hospital issue that we discussed before, one of the kind of complication is that since the small hospitals are performing better in general, then they also pull the benchmark, so it's making harder for larger hospitals to meet those benchmarks and get 10 full points. So when we looked at the data, so I created an example here to illustrate the problem. So let's say we have 10 hospitals, and for simplicity at risk, I just take 1,000 versus 10,000, and I created the ratios. As you see, it's from the best hospital to the worst hospital. So here, the expected ratio of 0.5, the hospital 1 is performing 50% better than the state average of 1. So with that, with the current methodology, we take the top 25% of the best performing hospitals. So in this case, we would pick only hospital 1 and hospital 2, and then recalculate the expected benchmark based on these 2 hospitals. So if you take these two hospitals, the expected is at 0.53, so 53% lower than the state average. But what the discussion is that in terms of the percent patients that compose these benchmarks is only 4% of the patients. So in order to correct that imbalance, what we are proposing is to make sure that we get the top 25% of the patients, not the hospitals. So if you make that change, then we would be picking up to hospital 7 and then recalculate the ratio, and that will make it to 0.68. So the impact of this change is actually varies. In some PPCs, it's increasing the ratio. In some, it's decreasing the ratio. And it's because of the weighted average of the whole hospitals. But in general, I think this will improve the way we are calculating the benchmarks and making sure that we have enough patient population to calculate the benchmark for the program. Any questions on that? So with that, we are planning to put this all together in a memo to communicate with the hospital, summarizing the changes, and also send out the baseline information. So that will include updated scaling points, hospital base year scores, and also probably updated case level for the base year and changes to the current performance period. So any questions on the MHAC before we move to readmission? Dr. Bhatt?
So this way of doing the benchmarking, if I understand it correctly, is it going to be based on the patients or the encounters? Because I'm just still trying to get my head around how that 35% of the patients will be translated into what the performance is.
35% of the hospitals, because you can't really pick patients independent of the hospitals.
Right.
So we are picking the top 25% of the hospitals weighted by their patients. So we are picking the top 25% of the patients, but it is attached to the hospital. Yeah, it's hard to communicate.
Is it the patient or the occurrence of the PPC? It's the patient.
At risk has to be at 25%.
It's at risk.
Is that helpful?
Right, but I think the measure itself at the hospital level is based on the discharges, right?
Right.
Not the patient.
Patient versus discharge.
So if a patient has 4
I'm
discharges,
sorry, yes, discharges. Right.
so if they have 4 discharges, all 4 will be counted
That's
for
right.
that patient.
They are. Yeah, I'm sorry. Yes, it is discharges, at-risk discharges.
So then the 35% of the patient population will translate into X percentage of the encounters that are in play. You see what I'm saying?
Not the patients. I misspoke. It's discharges. Top 25% of discharges.
Or perhaps based on the measure. If it's a patient-based measure, it could be.
It's not patient-based. It's all discharges. That's my bad.
Encounter. So the 35% of the encounters.
Yes.
Okay.
Mm-hmm. Dan?
Yeah, just to clarify, it's to get to 25%, we're taking the best hospitals until you hit 25% of the total population.
That's right. Thank you.
Quick question. Thank you for including this and the memo. That's always helpful. Because I've been asked, what do you think the timing is on the memo? Not to pressure, but just to expectations.
I am working with Chris to make these updates. That's why I was very much, the PPC list is finalized, so we can move ahead. I mean, our hope is that we'll turn it around fairly quickly. We just, in terms of creating the base period data, the memo is much easier than getting the base period data with these changes, but we can, we've already modeled it out for some of these things, so we should be able to, I would say, get it out within 1 to 2 weeks would be my goal. Maybe the case level files come a little bit later.
Got it. That's helpful.
All right. Moving on to the readmission policy. So this is partly presented at the Commission. Just to summarize what we've been discussing so far and the information we shared with you in a different and hopefully more high-level way. So as we discussed, we finalized the CMMI, so I'm going to focus on the CMMI measure first. With the refinement, our difference with the national estimate changed from 8.8% to 7.9%. So this was the issue that we've been discussing, that when you look at it, it wasn't about our performance, it was the way the readmission measure was defined differently between national and Maryland. And you know, I think the majority of the change kind of came from refining the 30-day period. So that requirement of the 30-day enrollment after a discharge really helped to get the measures comparable with national and the Maryland. And the next one was the exclusion of special licensed beds. So these are the psych and rehab beds in Maryland acute hospitals. It existed in our data, but in the national they were taken out. And as you know, the psych patients have high readmission rates, so it inflated our readmission measure compared to the national estimate. And there are some changes to the transfer logic, but that didn't have that much significant impact in terms of the numbers. So with that, we are starting at 8%, 7.9% difference between us and the nation in the base year. So our rate is 16.6 and national rate is 15.4. So when we look at the trend of these numbers now, our base year is calendar year 2013. As you see, we've been improving faster than the nation even before the all-payer model started. And then you see this slowdown in between 2013 and 14, both in the national and Maryland number. And after that, again, we picked up our speed and we are declining much faster than the national estimate, which is good news. So the agreement states that we need, every year we need to match the national progress and then close the gap 1/5 of that original 7.9 gap. So we had discussion last time between percentage points versus percent. So I provided both numbers there. If you do it on a percentage point basis, the national readmission rate declined by 0.1 percentage point. And if you add the 1/5 of the difference, then our target will be at 0.4% decline. And our current percentage point decline is at 0.6%. So we have a good cushion, if you will, for meeting our target for this year. If you turn them into a percent-based one, it's 0.8% decline for the national, and we are declining at 2.2%. And I'm sorry, 2.2 would be the target, and we are declining at 3.4%. So with that, it's kind of the way that we calculate the, so I provided this as a reference. So this is the 0.1% decline, percentage point decline in the national when you look at the calendar year 2015 projected number, and that equals to 0.4% target, and you see 0.6 percentage point current projected 2015, and with that you see the new numbers for that. You've been looking at the percent-based calculations, and I think in general, since we've been looking at it, I feel more comfortable talking through this one. So if you project the 0.75% decline continuing in 2016, our new target will be 1.8%. And this was updated. I think we presented August numbers last meeting, and this is now, well, no. We presented June numbers, and this updated to August now with the new numbers. And if you translate that 1.8% to an all-payer target, then for the all-payer one, the number based on just the way we do it right now is at 9.09%, which is lower than our current 9.3% on the cumulative basis. And that's reflecting the progress that we made in 2014. 50. So in terms of, it's all good news if everything holds the same for the rest of the year. So we did the monthly trend. So this is cumulative readmission rates, Maryland versus national. So let's focus on the national one. So that's the gray or the red one. So the way to read it, in January when we get the 1-month data, the readmission rate was declining at 0.6%. When we get February, the 2-month trend now is at 0.9%. So that's how you could read it. So by the time you get to December, that's our annual rate. So annual rates then for the red line for national trend is at 0.7% increase. So right now we are looking at the August time frame. So this is last year's. I'm just going to show you this year's quickly, but right now we are looking at the August trend. So if you think about it, we already have a lot of months, right? We are past the halfway. So you would think that as we get new information, readmission rate shouldn't change that much. But you see that even in the December, the numbers are jumping. So because of that, we are a little cautious about reading into the positive results that we are seeing. I expect that we're going to eat up that cushion we are building, but we'll see how much it will be. So this is the kind of the theme trend. So we use the August numbers. We have preliminary September, and they are showing that eating up, that the growth rates are getting closer to each other between national and the Maryland. So it is a cautious optimism that our performance so far is looking better than what we had last year. Any questions on these two graphs? And so I think MHA has a different way of calculation, and I think I know what they are going to say, but I'll have her, and I apologize for the ones on the phone, but we'll distribute and try to be more, explain them better.
So thank you for the chance to go through these numbers. They should be very close to the same numbers, if not exactly the same. I just organized them in a way that made sense to me so I could think about this more easily. So if we're looking at the chart on the top half of the paper, we see the trends, national and Maryland, starting with calendar 2011 and going through August of 2015. So it's pretty clear what the national rate is, what the Maryland rate is. Then the next column over, column C, is just the Maryland rate divided by the national rate, and that's our annual test. So our base year gap, I came up with 8.01, which I think is a rounding error compared to what the staff had, but it's close. And then our gap in 2014 was 6.42, and this year it's at 3.95, our difference compared to the nation. Our target gap, if we started with a gap in the base year of about 8%, and we have to reduce that by 1/5 each year, then that's a 1.6 percentage point reduction. Sorry, is that right? 1.6 percentage point reduction each year. So in 14, our target was 6.41 compared to 6.42, again, a rounding error. And this year, our target is 4.81 compared to where we are right now at 3.95. And then you can see for the target for 2016, it would be a 3.2, 2017, 1.6, and that gets us to the national average in 2018. So then moving over to columns E and F, we have the annual national improvement and the annual improvement in Maryland so that we can see what the trend is for change in those annual rates. So both Maryland and the nation were improving pretty rapidly in calendar 12 and 13. Some of that, I would say, is also one-day stay and observation policy changes. Maryland also implemented the ARR program in calendar 12, so that accounted for some of the faster improvement. And then in calendar 14, that slowed down a bit, but the nation went the other direction, whereas Maryland continued to decline. And then as of August, our national rate of change for the nation is an improvement of 0.62%, whereas Maryland is declining at 2.92%. So just to that's all just facts. That's all just how the data is shaking out, so that we can see that.
Can I stop you? The reason I think your numbers are different is when we do the August year-to-date, we take the August of 2014. I think that's why your numbers are slightly different than ours. So we do year-to-date comparison rather than taking the full year because of that trend.
Yeah, thank you. That's a good point. We did use the full base period to compare.
For the nation?
For both.
For both.
Anytime that when we compared the August 2015 year-to-date for Maryland and the nation, we compared that to the rate, the full base year rate of the prior year.
Not a comparable period.
That's
right. Exactly. So then what we did was say, if we look at what might we assume the nation would be going forward, like you said, that's the key thing in projecting what Maryland needs to do to hit that all-payer demonstration target next year. So we took a couple of assumptions. So the first one is our current state, where we are right now. This second one is assumption A. Let's say that the nation reduced their readmission rate to 15.25%. Then Maryland, to hit our all-payer target, our Medicare readmission rate would need to be 15.74%. And following those rows over to the right, that would be for the nation a reduction of 0.81%, and for Maryland a reduction of 1.52%, compared to where we are right now in August. Then the second, and what I would say is that if you look at the 0.81% improvement for the nation, that's greater than what the nation has been in the last calendar 15 and calendar 14. And then if you say, let's bake in a little bit more wiggle room, then take a second assumption where the nation may get to 15.15%. If we want to hit that 3.2% differential, then Maryland's rate would need to be 15.64%. And what that would mean as far as annual improvement is that the nation would improve by 1.46 compared to where they are in August, and Maryland would improve by 2.14%. So again, that 1.46 is a bigger run rate of improvement compared to where the nation has been. And then the bottom half of this is then taking these Medicare rates and translating that to the improvement on an all-payer basis. So if we take what Maryland's Medicare readmission rate would be, drop that down, then using what the difference between Maryland's Medicare rate, using the test data, and the all-payer risk-adjusted rate, that difference has been around in the high 19%, almost 20%, kind of climbing up a bit over the years. And that's the second column from the end, that all-payer risk-adjusted rate compared to the Medicare rate. So if we use 19.94%, then looking at assumption A, where we said the Medicare national rate would be 15.25, which means Maryland's Medicare rate would be 15.74. If you follow that all the way to the right, we come up with a 9.09% improvement needed from calendar 13. So again, trying to translate that Medicare test in the top half to the all-payer payment policy in the bottom, where we measure calendar 13 base period to calendar 16. Currently, where we are, I'm jumping up one line, our current status, if Maryland's readmission rate right now is 15.98% on this Medicare test, our all-payer risk-adjusted rate, 12.8% roughly. Moving that over, the difference that we would need to have to improve on an all-payer basis to meet that test, or where we are right now, is about 7.3%. So our target this year is the 9.3%. We've improved about 7.3%, and we're hitting that test. So if we went with assumption A, we would only need to improve to set that target, that readmissions policy target, at 9.09%, which is compared to the 9.3 that it currently is. If you went with the more aggressive assumption B of and Maryland's Medicare rate would be 15.64%, the all-payer risk-adjusted rate, using that comparable differential of 19.94%, the risk-adjusted rate would be 12.52, and that 12.52 compared to the calendar 13 base period would be a 9.66% improvement.
So the current target, according to your calculations, is somewhere between those two assumptions?
Right.
9.3 is what you were saying.
The current payment policy target, which corresponds to these figures in the far column on the right, is 9.3.
So that's sort of in between those two assumptions.
It's in between those two assumptions, right? So in my thinking about this, I would say that if we assumed that the nation was going to improve at 15.25%, that would be their rate in calendar 2016, then that payment policy could be set at 9.09%. If you wanted a little more, and that would still be an improvement from where we are right now, if you're following me.
Yeah, I do. I mean, the numbers are slightly different, but they are not that different from ours. So at the end of the day, if you correct that, make that correction, you may get to the same number. The question to me is, given where we are with the Medicare utilization trends, you know, readmission is one. Last year, we purposefully put aggressive targets on the readmissions because we were very concerned with our performance. We barely made it with the changes we had last year in last year's readmission target. With the change, like it helped, changes in the measure helped us to meet that target. With the trends we were looking last year, we weren't making our annual target. So that's why aggressive, we purposefully put an aggressive target on it, 9.3. And what you're saying is, if you calculate it now, this year's target, it's 7.3. And I think we are in agreement because national trend didn't go as far as what we put in the model. Because we assume the national rate of change will be much higher, so they're going to decline faster, and that's not happening in the data that we are seeing. But the question is, to me, if we are setting a target for calendar year 16 now, how would we set a target lower than the last year? You know, that's what you are saying to me, that the target would be 9. I mean, if I take the 9% target, that assumption A, that means that we are setting a target that will be lower than last year. Yet on the Medicare utilization, what we are seeing is our utilization is not declining as fast to make up our financial target. And and maintain the update levels for the global budgets, right? If we don't reduce our utilization, we are not going to be able to give a higher rate update this year because we are going to fail the financial test. So the dynamic there is, if we are reducing our utilization, where do we want to reduce the utilization? And to me, because of the readmission target, that's kind of, to me, the first priority. Let's put our incentives on reducing readmission and meet our target. So because of that, I don't think that it is reasonable to lower the 9.3 to in the third year one. Second of all, if you keep the scaling the same, we are going to be double paying for you know what I mean? Like, then it doesn't make sense. We need to think about how we are going to change the scaling to reflect those changes. To me, I think we should set for a higher target, not as aggressive as last year, but something that is higher than 9.3. We can hit our utilization reduction so we can keep the rate update kind of hopefully in the positive, but also it's still incentivized to reduce the readmissions. I don't think that we could take it back, and I want to open and get Trisha's, Bob's, and others' input on it. Bob?
Yeah, I think you're just reiterating what Donna said at the last meeting about concerns related to Medicare utilization and the balance between utilization declines and updates and the need to keep pressure on utilization. I'd also just point out that trying to just beat our target relative to the U.S. is one thing. I mean, we want to do that, but it's not bad if we're much lower or a little lower than the U.S. Reducing readmissions is not a bad thing. It's a good thing. In terms of quality metrics and also the utilization argument that you mentioned. And we are, as you showed before, as a state, quite high still relative to the rest of the U.S. And we should be striving to get better, not just to sort of meet the test.
I mean, from what you're saying, Shule, in terms of still targeting the Medicare utilization trends, it seems to make sense that you would target the readmission rates and trying to lower it. So it makes perfect sense to me what you're proposing.
So Shule, just to clarify, when we measure Medicare readmissions, are we talking about the entire population or just fee-for-service?
Fee-for-service.
So if we're just talking about fee-for-service and we have an environment that's moving towards more managed care, that denominator changes, and presumably we have potentially a sicker population of fee-for-service, potentially, if you think about some of the literature. So we have to think about that readmission rate could become harder to reach as we move forward and as the managed care environment increases in the state.
Well, it's not increasing in the short term.
That's right.
Right. So in the next year or two, it's not going to be shifting dramatically, and it's going to be years for it in order to see a huge increase in the Medicare Advantage plan.
But it's certainly not going down. And
it's not going down, but it's not a huge significant proportion of the population yet, and it's not growing. I mean, they have plans, they've got more plans are entering the market, but the growth isn't there yet. So I still think there's opportunity to target.
Well, and we're starting low, and the rest of fee-for-service, and in the other states, there's more managed care. So we're comparing potentially against that population you're worried about right now because there's more managed care outside of Maryland. So,
right. That's kind of a general, wider question how we are going to handle the growth when it happens, and that will impact the financial performance as well as the readmission one. But I think that statewide rankings that we shared in the last meeting, yes, we are comparing ourselves to the national average, but we are, we are quite at the bottom. So I do think that there is still improvement to get us a better place and also hit the financial target at the same time. Dr. Butt?
So I think the base calculation, even if there is shift towards more sort of alternative payments, really shouldn't change the numbers in terms of the base calculation itself of the readmissions. I suppose the assumption built into that question is that perhaps we're not being aggressive enough if there's a big shift in the fee-for-service population into more alternative payments and managed care type thing, then generally speaking, they tend to have lower readmission rates. But the calculation itself doesn't change, I don't think. I mean, you'd still be getting the entire discharge data from the hospitals, and whoever gets readmitted, that doesn't change. Because in some other measures, that is a factor because you just have a data deficiency on the claim filing from like providers and so forth. So there's some issues with the measurement itself when that population shifts. But at hospital readmission, the base measure itself doesn't really change from a calculation standpoint. The assumption would be that if a lot of fee-for-service moves into managed care, that by just doing that, they would reduce the readmission rate.
Right. On an all-payer basis, yes. You're saying that yes. There is actually a positive impact of the MA
yes.
on the all-payer readmission rate, and then we would worry about and Chad's point is we need to worry about that one vis-a-vis the national trend. And if the sicker patient stays in fee-for-service, it may not be as it may not be as easy to reduce that to the national level. Is that summarized? Okay. Any other comments? Tracy?
I want to ask about other considerations. So one of the things, let me start with this, I guess, that I'm not sure I would equate the need to reduce Medicare utilization, more so than all payer to make the model work. I'm not sure I would equate that with a direct link to the Medicare or to the all payer readmission target. To me, they're separate. Making big gains in Medicare reductions, utilization reductions, could come from addressing chronic conditions. It can come from readmissions. It can come from complications. It can come from all of those areas. So I'm not sure that if we just make an aggressive readmission reduction target, that is the best way to achieve our goals on Medicare utilization reduction. And what troubles me a little bit about making the all-payer target too aggressive is where we are right now with doing well on our all-payer demonstration. I keep wanting to say waiver, that's why I always hesitate. All-payer demonstration target, but yet seeing that we have a lot of penalties due to hospitals this year on readmissions, and we're hitting that waiver test. So that 9.3 was too aggressive, and if the penalties were assessed right now based on the data, the most recent data, that's like 40 million coming out of the hospital system, and I would say that's at the wrong time, and it's not appropriate for where we are on this test. So another way to address that is to look at other considerations. So we know that social and demographic factors play a role, the percentage of dual eligibles play a role. We're not completely satisfied with the risk adjustment. The nation has a more complicated way of doing it. We're not quite there yet. But all those other factors play a role too. And I know there was interest in looking at those, and I also know that those are complicated, and we're not quite ready to say this is the right readmission rate for this hospital. We're not really quite there yet. But is there a way to do some more work on those other factors and have them play a role in this readmissions reduction policy?
Yeah, in the next section, I'm going to go through some of those considerations. But in terms of if we're assuming we are going with the improvement model still, incentivizing improvement, I think this is a helpful discussion about the target and what the expectation is. And I see your point, and you don't want to link it. But if you have two goals, reducing utilization and hitting the readmission target, to me, having something higher than 9.3% hitting them both at the same time. So yes, there are other ways to reduce the utilization, but we are bound to reduce our readmissions too. So I don't think that, in terms of strategy, I think from our perspective, strategically it makes sense to have that goal to be on the readmission. More maybe, PQIs is in the PAU, so PQIs are going to come too. But why not address it in and try to get them both with the same type of goal?
So obviously the Medicare population is a subset of the all-payer population. Do we have a sense of what weight in Maryland it has on the overall all-payer readmission rate?
50% of the readmissions, more than 50% is on the Medicare population.
So I think it would have an impact on what happens to that rate then.
Right. Any comments from the phone? All right, so in terms of the cost considerations, so this is the year-to-date August hospital level performance. So in terms of their cumulative rate of change, and our reduction target, that line is 9.3. And as you see, 1/3 of the hospitals are meeting that target currently. With August, we have some more recent data, so 2 other hospitals joined this group. And then 1/4 of the hospitals actually have increases in their readmission rate. So that's kind of the current state from the hospital perspective. So what we did is, in the last years, we acknowledge all these issues, and we were committed to look at different, with the performance, see if there are things that will impact this expected 9.3% reduction. And from the recommendation, we wanted to look at the Medicare-specific performance, look at the socioeconomic adjustments, and also the impact of the denominator changes. So the idea was, if a hospital is reducing overall admissions, would that have a negative impact on their readmission rate? And I think if I would suggest to read the recommendation if you want more kind of detail. We had a lot of tables and outlining the considerations there. So as a kind of picking up from that point, so this one is a graph looking at the readmission change to a Medicare one. So the x-axis here is the Medicare readmission change, and the y is an all-payer change. So each dot are hospitals. So at the very corner, there is one hospital that the Medicare readmission is declining less than 0.2%, actual 2%, and on the all-payer, it's 2%. These are percent, 24% to 20%. Sorry, that's the scale. So in general, if they were all one-on-one, you're going to see a straight line going right through the middle. And what you see here is the straight line is below the middle, but still there's a strong correlation between Medicare readmission declines and all-payer readmission declines. There are some exemptions in the hospitals, but in general, statewide, this is telling us if we improve on an all-payer, we are improving on a Medicare. And the correlation coefficient is at 0.8, and the range is 0 to 1, so this is a very strong correlation at the state level between Medicare and all-payer. So this is addressing the question we had last year: should we set 2 targets, all-payer and Medicare, because we're taking a risk of not hitting the Medicare, but right now the trend is saying all-payer target is going to get us what we want from the Medicare readmission target. Then the next one is looking at this by hospital. So the blue, you've seen this, that's the current performance on an all-payer, and the orange line is their performance on Medicare. So if we are doing, to address the question about we are doing good on the Medicare, but we have a lot of penalties from the all-payer perspective, would we take into account some of the Medicare performance? And, you know, there is a variation. So, and it could, you know, we haven't looked in too deep, but let's take St. Mary's. They have more than 20% decline on a no-payer basis, but no change on their Medicare performance. And on the opposite side, on one of the penalties, let's see, who is this? Laurel Regional. They are, you know, at that 9.3 on the Medicare change, but on a no-payer basis, their change is around 5%. So we think, you know, there is some value in looking at this and thinking about the payment adjustments in terms of their Medicare. If we are kind of in agreement that, yes, we should take into account our Medicare performance, if they hit the CMMI target this year, is there a way to incorporate some of this Medicare-specific trend for the hospitals who are penalized in a no-payer basis? But in general, if you look at the ones that the readmission rates are increasing, that group that is below the 0% at the very beginning of the graph, you know, their Medicare trends are also increasing too. So, you know, I would be very concerned if those were on the opposite side. But because Medicare is such a big percent of the readmissions, in general, they are moving parallel to each other. Any questions or comments on the Medicare trends so far?
I like this idea of looking at the Medicare in addition to the all-payer, particularly for the ones where it's really different. And then the other question that I had was on this, the left side of the scale where we have hospitals that are increasing, do these rates vary much? I'm looking like Easton, Garrett, the University of Maryland Rehab and Orthopedics. I believe they have pretty small volumes. Are those rates more variable for them?
Yeah, we are looking at the change year over year to get that in. So yeah, that's a good point. And I have some other slides to look at their level of readmissions in a bit.
I think the only one, I can't read the bottom of this, that is sort of in a totally opposite direction, is this one next to Shady Grove, where the Medicare is up and all payer is down. That's the
Dorchester, is that?
Yeah, that's the
small hospital.
That's the one that's a little bit of an outlier in this data.
Yeah. Then the next one is looking at the socioeconomic status, and as you know, we have a subgroup on this. We met early fall, and we've been trying to update the index and look at this analysis. And the area deprivation index is basically pulling a bunch of information together and getting rid of the correlations and coming up with the deprived to affluent zip block group level. So it's lower than the zip code, and combining education, income, poverty, housing cost, housing quality, employment, and single parent household. So when we started this, the index was based on 2010, actually 2000 census data. We wanted to update it to 2010, and in the process we discovered the census surveys, population surveys, and we updated to 2013. So it's a more recent index, but there are some still issues in the refining the measurement, so it's still a preliminary index. But in general, you could, we could share you the patient level one. You do see a strong correlation between ADI and a readmission rate at a patient level. So patients coming from most deprived areas have high readmission rates, even after controlling for their case mix. But at the hospital level, it's more complex, whether, how much of it impacts the hospital level readmission once you control the case mix. So since we are looking at an rather than dealing with the attainment problems, we just wanted to see, okay, do hospitals who have most disadvantaged patients, do they have a performance issue on an improvement basis? So this is the kind of a similar graph that you saw on the Maryland all-payer versus Medicare. Now, instead of Medicare, now what you have on the x-axis is the percentage of patients who are coming from the most deprived areas. So that's the cutoff is 85th percentile, and we are still working on that exact what that cutoff would be. But here you see a kind of a random plot of improvement versus the ADI. So there is no relationship in terms of improvement perspective, the percentage of patients coming from deprived areas vis-a-vis the readmission reductions. I'm talking about reductions. I want to emphasize not the readmission rates themselves. So that's kind of looking at the ADI on an improvement basis. And just as a reference, and we are hoping to prepare like a table to give this information to the hospital so they can start looking at the ADI, how it works. But this is the same graph, but now I put the hospital names on it so we can get a better sense of how the ADI is working out. So the highest percentages are in Bon Secours and Midtown, with more than 50% of their patients coming from most deprived areas. And that's what we, in general, know about these two hospitals. And then you see a second group of hospitals that between 20 to 40, or 35% of their hospitals are coming from most deprived areas. And then you have another group that less than 10% of their patients, coming from most deprived areas. And kind of in terms of, I just want to put cautionary, as I said, we are working on this 85 percentile cutoff. So this is a graph looking at the average ADI versus most deprived. Obviously, we are looking at the extreme on the 85 percentile. On average, maybe these hospitals may receive patients from not most deprived, but still more than average poverty. So in this chart, you could kind of look at so the bars are their average ADI, and the line is the percent coming from the most deprived. And in general, there are some differences, but in general, I think average and the percent ADI is quite correlated. So, but there are some exemptions. So if you think about this, if they were one-on-one correlated, this line would have been straight as well, right? Because the bar charts are from lowest to the highest, and you would see that the line would be also similar to it. But you see that the Garrett County, they do have they are in the middle in terms of the average ADI, but they have a very small percent coming from the most deprived areas. So the next item that was in the recommendation was looking at this denominator issue. And even at that meeting, we had a big debate about whether, since we do a case mix adjustment, whether the denominator impacts the rate. If we didn't do any rate case mix adjustment, the idea was if the hospital is reducing their admissions, their denominator is going to get smaller, but their readmission is going to stay the same, so their rate is going to be higher. But since we do case mix adjustment, we believe that that wasn't the case in our measurement, and what you see here is actually kind of a supporting data that there is no relationship. Actually, that's an opposite relationship. So if hospital is reducing their admissions, they're also reducing their readmissions. And that makes sense to us. If you are putting a program out there for a follow-up, you are improving care, and it should also reduce the admissions at the same time. And with the case mix adjustment, we are taking into account any changes in the risk of readmission. So then the big, like, those are all, to me, it makes sense, and it seems like, you know, there are ways of looking at it. The main issue here is whether your readmission improvement depends on your base level readmission rate. So in this graph, what you have on the x-axis now is the calendar year 2013 risk-adjusted readmission rate compared to the improvement levels. And here you see that the line is actually the higher the readmission you have in the base, the more improvement we see in the data. So, and then I try to color the dots based on their ADI percent of their patients coming from most deprived areas. So the red dots, you see 4 hospitals that have a high readmission rate, have high ADIs, and they improve the most. On the top, the dark greens, those are the hospitals who actually, when you say it, you know, they have low readmission rate, yes, they do have lower readmission rates, but they also have better socioeconomic status. So it is hard from, you know, to bring those all together and judge what the improvement target would be, given that they, you know, we don't really know if they have a low readmission or not because they have a better socioeconomic status of their patients. So I think the complication is here in this graph, how you would take those 2 aspects into account when you look at the improvement.
And maybe if I'm remembering right from back from that presentation in the fall, it was really the people who lived in the 85th percentile of deprivation. They were really the ones who had the higher risk of readmissions, whereas everyone else was sort of the same. So to me, I think this graph tells me the same thing. It's those 4 hospitals with the large proportion of patients who are in that highest ADI have the highest readmission rates, highest opportunity, they've improved, but everyone else is sort of the same regarding ADI. So more of what I take away is that higher readmission rate equals more opportunity to improve.
Yes, but I don't really know. So if you just look at vertically between 11 and 12, you know, there might be the one at the 7% all the way out, right? That's kind of the outlier. On the other hand, in Garrett County, so their readmission rate, risk adjusted, is around 7%, and they have a readmission increase. You know, that's kind of one hospital all the way. Then if you look at the range of between 11%, if you kind of draw lines, and I wish I had the thing to draw here, if you do like a vertical corridor, the performance varies quite a bit, even within that range. So it is hard to say in that range what the expectation would be if a hospital's readmission rate is between 11% and, you know, if you keep it narrow, even 12%. You see the variation is quite a bit there. So if I look at it, I could say, I could show you one hospital that improved and one hospital that didn't, and they have the same baseline readmission rate. So how do we explain the difference in those 2 hospitals, given that they have the same socioeconomic status profile and a similar readmission rate?
I think that's where I mean, I see what your point is, and I would even draw the corridors like between 11 and 15, where the bulk of the hospitals are, and you're clearing out the outliers. But I think, to me, that's where the questions about the other factors, more detail on the risk adjustment, play a role here, and that if we look at any one factor in particular, whether it's what the primary payer is or what the diagnosis profile is, that those tell part of the story, but they don't tell the whole story. And to really get an idea of I don't know which hospital this is, but one at the top that had a low readmission rate and their rate went up. What else is happening there? And I think if we look at just each of these criteria in isolation, it's not going to tell the whole story. So that's why I feel like we need to do more work trying to understand the interactions of the different factors. And I don't know if that work is going to come back to this group or that's going to be something else that the socio-demographic group takes on. But I think that's really important to get to as we continue on this path of improving readmissions.
Right. So I think, from this, one thing is if you look at the Medicare improvement, that may explain some of these. And if you're hitting the Medicare CMMI target, there might be some adjustments there. We are looking at the observation, cases and recalculating this. Looking at the observation is the other one. The third one is what we notice is these low readmission rates are on our borders. So using the Medicare, we are trying to come up with a readmission rate that takes into account the border crossing, imputing it from the Medicare data to the non-payer to see how this shakes out. And actually, I did preliminary work. It wasn't ready for share yet, but Garrett 7.7 moves up a little bit, but a lot of the hospitals on the very top, they get to the 10, 11% ranges quickly with that adjustment. So those are we are also thinking about, in those lines, are they doing better on the PQIs? I mean, if, is PQI performance could help us to say, okay, maybe you are not doing well on the readmission, but are you reducing your PQIs? But I didn't see that much improvement for these who have especially on the increase. If they are increasing their readmissions, they are also increasing on their PQIs too, I'm afraid. So their performance, we are looking at all these things, but at the end for the adjustments, we're looking at their readmission rate, and there seems to be no other positives for these hospitals to explain why they are not improving.
And I would encourage too, I'm not trying to make any excuses for performance that isn't where, but I would also encourage looking at some of the hospitals in the middle too, that maybe aren't quite meeting the 9.3 target. Maybe they're at 5.5 or something. I don't know. I'm just making this up. But there might be reasons why that reduction is a good reduction for that hospital. I don't know.
I mean, you come up with it, and I'll be happy to discuss it. The way we've been looking at it, I don't think there's an easy way to do this. And I think at the end of the day, 9.3 was, to me, a cumulative 2-year target. That was the target, and that's the policy. We are going to look at the Medicare. We are going to look at observation stays. But beyond that, I think if it was easy and be done, we would have done it already. And we kind of agreed that that's what we are moving forward. Dr. Bott?
So let me see if my understanding of this makes any sense. So it appears that certainly at the hospital level, the percent change is not correlated with the ADIs. So obviously, you can't apply the ADI directly to any kind of reward-based system based on that percent change because there's no correlation. However, there is very strong correlation, it appears, between the actual readmission rate and the ADI.
Yes.
Right?
Yes.
So that would really suggest that perhaps if ADI was used as a risk adjuster and the targets were also inclusive of ADI for the benchmarks, that would, in a sense, account for this difference in the risk adjustment methodology. So it would adjust everything. It would obviously create a problem as it correlates with what we have with the Medicare piece of it in terms of the adjustment part. But internally, it would make sense because there's appears that ADI has a strong correlation with the actual rate. And so if you adjust that, and incorporate that into the benchmark, then you're basically accounting for whatever the difference, however that difference is impacting the rate, you're accounting for it.
Right. I think the question, though, is that will shrink this variation to the middle, right? If I adjust for it.
The benchmark would move as well, right? If you incorporated it in the benchmark, then you
So
would
you're saying put separate benchmarks for different ADI levels?
I'm saying that the risk adjustment would be inclusive of all the factors that are currently being used for risk-adjusted rates, would include ADI as a variable in your risk adjustment model. And that flows across the board, including the benchmarks. And so now you're comparing apples to apples and to the benchmark, the same methodology, which incorporates the fact that there is strong correlation between the ADI and the rate, the risk-adjusted rate that doesn't incorporate ADI.
Let's take an example. So if I ADI adjust their rate, it's going to come from 10% to 15%, let's say, for a hospital.
It would depend upon what their ADI is.
That's right. But in general,
in fact, different hospitals different.
Right. One hospital I'm taking an adjusted ADI would be from 10 to 15. But then we are putting a improvement target of 9%, let's say. It's still 9% of the 15 adjusted. So there is no, in general, there is no change in the ADI percent of the hospitals. Let's assume that from year to year, you're not going to change your ADI profile from year to year.
It may not affect the improvement side of it, but it will impact the attainment side of it.
Right, but right now in the program, we don't have any attainment. And there is, for us, this is an improvement. And then if you're putting that 9%, how do you vary that based on their readmission rate? Or, you know, because we couldn't come up with yet, because of the risk adjustment issue, to have a program that will combine the two on an equal footing like the AMAX. We kept it on an improvement basis. Now, how do we give some leeway for a hospital that have a lower readmission rate that won't be improving at the 9% level?
But I think at the end of the day, it's also important to have the attainment, yes. Right?
That's right. Yes,
and
that's
so
our goal.
If you incorporate that, then this would be a perfect risk adjuster for that attainment goal, because then you are accounting for something, and we still don't know what the components of this difference are, because I remember when we discussed this earlier, there was something going on with people in Baltimore County that, or Baltimore City, was it, that had insurance that the ADI kind of was a little bit out of kilter for that group of people. Right. And I don't know if we had further analysis of that. But in general, it looks like at the top level, the ADI appears to be very strongly correlated with the readmission rates. And the purpose of risk adjustment is generally to account for things that account for variation.
That to me is a larger discussion, what do you do with the attainment? So then the critical question to us is, do we move forward with the improvement rate, again, work on the ADI, and then see if the shared savings could be incorporating the ADI, where we have an attainment level, or do we hold on to this program, spend more time on it, and do a retrospective policy decision, and put that policy, starting with January, but this may be done then by April, May, and that will eat up the time period. So we need to balance, how much we can get done and give hospitals the incentive that they can work on versus creating a program where attainment and improvement is kind of combined together.
I can speak to timing-wise. Timing-wise, from the hospital field perspective, they're already off and running on readmissions, and we know basically what the measurement is, and those, you saw the grants, and we talked about the transformation and all of those plans. They're going ahead, and I think because of that and the incentive that's inherent within the global budget, we're going to continue to see readmission rates decline, and we're going to continue to see that go on. So from a timing point of view, I think there's more of an appetite to work more on these other factors and see if we can work them into a policy in one way or another, taking another month or so to do that.
Diane Lipley asked a question whether we examined the relationship between observation status and readmission rates. We are looking at that, and in general, the reductions are smaller when you incorporate the observation cases. And there are, we may kind of contact with a few hospitals that the relationship is quite wacky, that you see an inpatient readmission rate declining, but once you put the observation, it is actually increasing. So we would want to see some of that data, in more detail, and then I think the plan of action is to understand what the hospital is doing with their observation cases.
I just had one more thing.
Sure.
There's a lot of really good work that's going on around this, and it's hard, and we appreciate all this thoughtfulness going into it.
So, thank you. The question I have is, you said hospitals are working, so how would they, what the message is from us if we are delaying, whether they need to move aggressively or no, we met our target, now you can be, well, what is the message that we need to give to the hospitals if we are going to delay this, a couple more months in terms of the readmission progress?
I think it's that there's still a continued pedal to the metal on readmissions. We're not setting a target yet. We're not, it looks like we may do readmissions reduction, but we're also aware that there are other factors influencing readmission rates. We've heard those concerns, and so we're taking more time to look at those.
So would you give them, even though it's not in the payment, would you give them a 7% target, or would you give them a 10% target? I think, in terms of messaging, we may want to discuss that a little bit further, what we think as a group, what that target is. At the end of the day, whether we make an adjustment or not is, a question, but what is the message to tell them what the expectation is for the readmission rate?
So I think as a just sort of neutral observer, if you want to call it that, to me, I think, the 9.3 seems reasonable because it's in between the two sort of, I guess, best case, worst case scenarios. And also the 1.6 per year reduction is not going to be a straight line, because if you even look at the data itself, these things jump around year to year. So you need to have a little bit of that cushion around that mean. And so it would appear that it's not unreasonable. It's not on the one end of the spectrum or the other. It's kind of in the middle, so it's sort of splitting the difference.
It's not in the middle. In my case, actually, my work
based on what
MHA, right?
Yes. Based on Tracy's calculations, if they can be transformed into what you are showing, that appears to be in the middle of what her concerns are.
Right.
Her two sides of the assumptions. So you're not on the high end of her assumptions, if you will, right? You're kind of in the middle of her.
I'm in the lower of my assumption.
Right.
On my range is from 9% to 13%.
I was addressing her concern.
Right. So yeah, I mean, even in the range, we can.
I think
we don't get a good assessment because it's hard to predict.
So if I had to pick a number today, I think the 9.3 on her sort of assumptions would seem reasonable. But
I mean, I think without knowing what or if there warrants an adjustment factor, it seems like whatever target, the preliminary target should be what we would set and assume that there is no adjustment. And then we can continue to have discussion, but be clear with the hospitals that this is where it's going. We're still investigating. Preliminary data does not show a correlation. We'll still be researching it, but at this point, this is what we would recommend as the reduction target.
Mm-hmm. Bob?
Yeah, obviously our preference is to be aggressive, to make sure that the hospitals push, firmly on that pedal moving forward for the reasons we mentioned. We want utilization declines, and we also want improvement in the number of readmissions and our readmission rate because we are quite high. Just meeting the target is not enough. We should be below it. I do think that there are some legitimate things that should be looked at with regard to hospitals that have very low readmission rates, but what we should talk about what constitutes a low readmission rate, because for Maryland standards, a low readmission rate, when you compare it to other states, may not be all that great. There certainly would be some point at which a hospital may be so low that you wouldn't expect much more improvement or maybe any improvement. And that's a fair question, so we should investigate that and maybe calibrate it relative to better practice on a national basis. Mm-hmm. But in the meantime, set an aggressive target and get that message out there, Tricia said, and then let's work additionally, hopefully not making too many complicated adjustments to the methodology, but recognizing attainment when it was truly attainment.
Yeah, it reminded me, we did look at the hospital-wide readmission rate. Only 2 hospitals is better than the national average in the state. And that one of them is Frederick, and the other one is, remember, GBMC? GBMC.
And that's the data through?
Like 6 months lagged. But those are 2 hospitals that are better than the nation without consideration for the socioeconomic adjustment. So even in the national one, you could see that.
Question about that. When you're comparing Maryland hospitals to the nation, is it possible to compare the CMMI defined readmission rate to the nation? Because I know that IOM report just was kind of the raw numbers that are reported and not necessarily definitionally apples to apples.
So this number came from the Hospital Compare risk-adjusted hospital-wide readmission. There are some differences between CMMI definitions and the hospital-wide one, but not that much. So I do think that it is comparable on a risk-adjusted basis. Yep, that's a good point.
So just to be sure, I wasn't suggesting 9.3 on your number. Whatever that translates into, I think it translates into the 9.09, right, on your numbers? Or what does it translate into? What Tracy was saying.
Well, assumption A, I think, is on her sheet is the same as what we come up with, 9.9. 7.2, she's calculating is the last year's. If we set the last year's target, that would have been 7.2 as opposed to 9.3. And so at the end, I think we are starting from the same 9%. Assumption B is at 9.6. And we said because we don't really know what's happening with the trend. If the trend picks up, because it went down without us anticipating it. If it picks up again, what would that higher barriers? We don't think it's going to be 12.2%, but that's kind of the range, if you will, between 9% to 12%. That's, to me, is the range for us. Okay. So let's finish the aggregate at risk discussion, and then we'll see where we are with the final. So on the aggregate at risk, I went quite. Wait, I'm going back. No. So the all-payer model gave us exemptions from HAC program and the readmission reduction program in exchange for the specific targets on those 2 measures, and also a requirement that we match their aggregate at risk combined with all these programs. So this gave us a flexibility in allocating risks on each our programs, but at the end, we are required to meet the total percentage risk between Maryland programs and the national program as a whole. So this is kind of, and then on the measure side, we've been working with the CMMI staff to see how do you operationalize this requirement, and they came up with two different ways of looking at it. One is looking at potential at risk, and the second is realized at risk. So in our programs, when we set the maximum penalties, the way that we structured our programs, maximum penalty may or may not be applied to a particular hospital. So because of that reason, they wanted to ensure that we also have a meaningful amount on the realized at risk concept. So on the potential at risk, if we focus on the 2017, what we have is on the AMAX program, we have 2% maximum penalty. On the readmission reduction program, we have 2% maximum penalty. QBR program is 2%. And then in the shared savings and the GBR-PAU adjustments, these are the actual adjustments that we calculate each year, and the maximums assessed for 2017 is for shared savings 1.3% and for PAU 1.1%. So one hospital received these maximum reductions in their GBRs. So when we total them all up, it's at 9.45%. On the national side, the HAC is at 1%, readmission is at 3%, and VBP at 2%, and their total is at 6%. Then when we do the difference between Maryland and the national number, we do a cumulative difference. So for 2017, on the maximum, we are 5.5% higher than the national aggregates at risk. So the way we make the adjustments are completely different from the national one, and that's why we are looking at the realized at risk calculations. So the realized at risk is, now we are 1 year back, so we are looking at 2016, because we haven't finished the 17 realized at risk yet. So on the 16, we had on the MHAC, so the first one is the total net amounts. So overall, the MHAC scaling resulted in 6.7 million additional revenues distributed to the hospital industry. And the penalties were at 1 million, and the rewards were at 7.8 million. So when you total them up, the net impact is 6.7. The potential at risk that we said was at 4% for MHAC, and the maximum adjustment we had was at 1%. So one hospital, so this 1% is actually the reward side. So since these are absolute, our maximum at risk is at -4%, and the largest adjustment turned out to be a 1% award for the hospital. So when we average them all out in the scaling, average adjustment, positive or negative, was at 1.1%. So as you see, there is a big difference between our potential at risk of 4% to our maximum adjustment and also our average realized adjustment. So on the readmission program, we distributed 9 million in the program, and in 2016 this was only a reward program, so we had no penalties. And in this case, our potential at risk was at 0.5%, and because the way we structured the program, the maximum reward was at 0.5%. If you remember, if you reached the target that year, you got your 0.5, and there wasn't any scaling done for the result. And this, in the 17, we changed that. So when you add all the hospitals who didn't get that 0.5 overall of the 46 hospitals, then the average adjustment we made is at 0.15. On the QBR, for 16, it was a revenue neutral scaling. So we made sure that the rewards distributed were equal to the penalties. So the number is 12.8 million. Our potential at risk was at 1%. And in this case, it's the maximum adjustment also done at 1%, because the scaling back then was revenue neutral and relative. So the worst hospital got that maximum penalty of 1%. And then on average, it was 0.3% adjustment. On the shared savings, the total reductions were 27 million. Shared savings is reductions across the board, so there is no rewards. And as you see, the potential at risk was 1.3%. The maximum adjustment is the net adjustment. So since we do this year over year, on an annual basis, the maximum adjustment was actually 0.4. 1.3 is our cumulative impact that we measure, and 0.46 is the annual update impact for the hospital. And on average, it was set at 0.3%. The PAU adjustments total to 26.9 million, and here we don't set the maximum. It's kind of because the way demographic adjustment works, the maximum and the potential at risk is at 1%, and on average, the reductions were at 0.39%. And the PAU adjustments are done on the increase, not on your base. So hospitals received 0.3% less increase in their GBRs, as opposed to all other programs where that's an actual reduction to the GBR budget itself. I know this kind of is hard to get your heads around, but I promise I'll do a better job next time. So then when we total them all up, as a net impact, we have negative 38 million when we add all this together, and penalties were at 68 million and rewards were at 29 million. On the potential at risk, our number is at 7.9%. Our maximum adjustment realized is at 1.9%. And when you average it across the hospitals, it's at 1.6%. So the 1.9 maximum penalty is one hospital across all these programs received a reduction of 1.9%. And when we average them across the hospitals, then when we add them all together, the last row, then we arrive to 1.6% as a whole average. So it's not the net impact, but just the summation of all the programs. And that's how realized at risk is working for the CMS. Dr. Butt?
The maximum adjustment, absolute numbers, the 1.95%, is that a net maximum? So was the maximum always a negative number?
Yes. Yes.
So even if somebody had a reward somewhere, in the end they actually ended up.
Right, because majority of the time our penalties are more than the rewards. Rewards are set at 1%, but the maximum penalties are 2-3. So when across the board, net impact is usually a negative number.
So the best you could do is to reduce your penalty.
Yes. I mean, I don't know if if you score best in all those programs, 1% from MHAC, 1% from QBR, and then you're going to subtract whatever your shared savings and PAU, you may end up as a positive. I think there are a few hospitals who are receiving a positive adjustment.
So that's what my question was, and then the maximum should be a positive and a negative number.
I could add, I did it absolute, but we can add maximum penalty and maximum reward. Yeah.
This would imply that there's only one direction you go.
The problem, I'll do that. But in terms of the CMMI mind, we kind of said, don't worry about it's a penalty or reward. Look at it in absolute terms, and this is about value-based purchasing. How much of revenue is kind of adjusted for the value-based purchasing. But we'll add the penalty and the reward. That's it.
Yeah. Also, one more question. In terms of the contract with CMS, are those the only 3 at-risk programs that we are compared against? Because I think there's another 2% in there that is the IQR reporting with meaningful use combined, so that the total at-risk is 8% on the CMS, straight CMS side, but we may not be compared on just reporting for IQR, and now it's being combined with the meaningful use program, so that may be an exclusion, but I just wasn't sure if that was included in the contract or not.
It is. IQR reporting is included, and compliance with meaningful use.
So that is another 2%. So that's an 8% on the, not 6% on the CMS.
It's just, it's not performance-based. It's participation-based.
It's pay for reporting and achievement of meaningful use combi. But the total there in aggregate is 8%, I believe.
Okay.
You may want.
Okay. So after all this, you know, in terms of the comparisons on a potential at risk, we are way above the national levels. Or when you add the 8%, actually, we might be closer than what it looks like. On the realized one, the numbers are very close with the national one because the national, whatever the maximum risk, they apply that. So I just want to keep that dynamic when we discuss what we are going to be proposing for 18.
Thank you for walking through this. This has always been a hard calculation to really understand, and it's a little bit easier this year. It's still confusing, but it's easier, a little bit easier. I just need more time to let it sink in. On this calculation, I know we compare to the nation. Is there a number that we compare with nationally, and if so, which box does?
Right. The realize we don't have the national numbers yet. When we have it, we'll give it. Last year, this 15, we had the 15 numbers I'm not presenting here. We were like a percentage point or 2 higher than the national. That's it. Okay. And I don't think that their number is going to change. So we'll put a national comparison to it. So then the next one is a similar one during year-to-date one because we changed so much on the scaling methods and all. So I'm not going to walk through it. It's similar concepts just to point out that to make it comparable on the QBR, I took the attainment one. So this is overestimate of the penalties. Because if we were to do a revenue neutrality, maybe I should do revenue neutrality adjustment on it. That it would get to 9 million. So right now it's showing 59 million penalty because I just took the base year, and as you improve, this is going to go down. And as you see on the MHAC, that we right now have no penalties to any hospital because we meet the state target, and hospitals are either on the no adjustment zone or on the rewards side. And 26 million is the rewards for hospitals who are in the reward zone. And similarly, on the shared savings and PAU, since those policies are not determined, I just took the numbers from the last year. So we can do a kind of comparison. I think I should probably correct the QBR one. But then you kind of see that our realized at risk or realized adjustments are much higher this year, and that's a function of the readmission program because now we have a 2% penalty on the readmission. So if so that's 0.7% average adjustment compared to 0.1% last year. And I think last year we really wanted to emphasize the need for reducing readmissions, and in the adjustments you could see that increase of the impact of the readmission adjustments in general. In addition to setting targets, increasing the revenues at risk was the two, those two impacted the emphasis on the readmissions. So with that, right now, staff is planning to keep them same as what we have in 2017 for these programs. So we are proposing no change, 3% penalty for MPAC if we don't hit the 6% target, 1% if we do. And for the readmission reduction program, keep it the maximum penalty as 2%. And for QBR, it was approved in the October meeting at 2%. So on an aggregate basis, and then we'll think about the way that we do the scaling. But in general, our intention is not to make changes to the scaling or the percentage risk since they went through a big revisions in the last 2 years.
Yeah, just on the readmissions amount at risk, that may be something that we want to rethink as it's all part of looking at the penalty. I mean, looking at the policy. Mm-hmm.
You mean the kind of the adjustment in how we do the penalties?
Yeah, looking at any adjustments, what the target is set at, kind of they're all pieced together. A more aggressive target can be more acceptable if there are more considerations or lesser penalties. Mm-hmm. But the higher you make the penalty, the fewer considerations, then that leads us to want a lower target. They're all kind of combined. Yeah.
Well, that's why you didn't see any draft recommendations from us in the January meeting. I kind of guessed that a little bit. But, as we delay it, then these are also delayed too. So, if you delay the readmission program, maybe it might be prudent to put these out there as a draft recommendation, knowing that they may change once we finalize. We may need to think about that, just that everyone's aware what the intentions are. Any other comments or questions? Anyone on the phone who have any comments? No? All right. Thank you, everyone. Next meeting is February. I don't remember. It's the same. I think so. Yeah, Wednesday.
Payment work group, is that ever going to reconvene, and would it reconvene around the update factor, or what's the thinking?
I believe that's what the plan is.
Yeah.
Yeah.
When do you expect that? Roughly?
Well, I guess we didn't mention the advisory council meetings coming up, so I think we need to go through that process in February. So I would think after the advisory council meeting that staff may have time to think about that. All right, thank you so much, everyone.